Eus-Guided Antegrade Stenting is one of the most technically demanding procedures in interventional endoscopy and carries a significant risk of adverse events, including bile leak and perforation. In this Florida Live educational video, we demonstrate a systematic, step-by-step approach highlighting the critical technical principles and decision-making strategies required to maximize safety and optimize clinical outcomes. This 57-year-old female presented with severe jaundice secondary to a complex hilar stricture from a gallbladder mass. At EUS, a large infiltrative gallbladder mass was seen invading the hepatic parenchyma. Final biopsy using a 22-gauge FNB needle revealed adenocarcinoma. As the patient had gastric outlet obstruction, a Eus-guided gastroenterostomy was performed. Also, as the papilla could not be accessed, a decision was made to perform extrahepatic biliary decompression in this patient with malignant stricture at the liver hilum. The B2 or B3 liver segments are ideally suited for extrahepatic biliary drainage and can be best accessed from the proximal stomach. It is important to confirm manually on endoscopic view that the hepatic duct is not accessed from the distal esophagus. The peripheral intrahepatic duct closest to the EUS transducer, dilated adequately to facilitate guide wire manipulation, and which can be accessed at a convenient angle, is chosen as the puncture site. The bile duct is accessed with a 19-gauge FNA needle that is primed already with diluted contrast. It is important not to obtain an air cholangiogram as it obscures the view of the ducts, and accidental air insufflation of the hepatic vein has resulted in fatal cardiovascular compromise. Once the bile duct is punctured, it is important to obtain a fluoroscopy image as a reference image. This is critical because if the plane of the transgastric access angle is displaced, a reference image will help the endoscopist to adjust the shaft of the echoendoscope into the correct plane to pursue further treatment. A 0.025-inch guide wire should be coiled generously within the liver hilum or into the duodenum to facilitate accessory exchange. As antegrade stenting carries less complications than a hepatic gastrostomy, every attempt should be made to traverse the guide wire across the hilar stricture. If the guide wire cannot be advanced to the duodenum via the FNA needle, then a catheter or a cystotome should be anchored at the stricture site to facilitate this. A 6 French cystotome is then inserted over the guide wire. It is important to maintain the plane of the transgastric access. The guide wire should be visible on sonographic view at all times. If needed, an assistant should be encouraged to brace the scope at the mouth guard so that the wire is constantly visualized. The wire should be locked in the elevator at exchange and then gently lowered to enable cystotome-induced transgastric puncture via cautery at the same setting as the Axio stent. Please visualize the seamless cystotome passage from the biopsy port and into the intrahepatic duct on sonographic view and on fluoroscopy. If there is resistance, bring the guide wire in view at EUS and reattempt the puncture. Once the cystotome or catheter is advanced to the liver hilum, a straight guide wire can be used, if required, to traverse the stricture and into the duodenum. This requires extremely fine torquing. After coiling a generous amount of guide wire into the duodenum, the cystotome is exchanged for a 4 by 4 mm hurricane balloon. The balloon should be first advanced to the ampulla for dilation. It is then retracted so that the transgastric tract is dilated to 4 mm or less, again on sonographic view in plane of access. It is important to dilate the ampulla first and not the other way around, as a partially inflated balloon will not traverse the papilla. Once the transgastric tract is dilated, it is important to proceed efficiently and in a timely manner to minimize bile leak. Continuous suction should be applied and the guide wire should be anchored tightly at the elevator so that there is minimal bile leak and pneumoperitoneum. The stent of correct choice should be kept ready before the balloon is withdrawn into the instrument channel. For antegrade procedures traversing the liver hilum, always use an uncovered metal stent. For hepatogastrostomy, a partially covered or fully covered stent may be used based on regional availability. The endoprosthesis chosen should preferably be 8 mm or less in diameter, as they are flexible and easier to navigate. The endoprosthesis should be advanced gently in the plane of the guide wire into the liver. If resistance is encountered, it oftentimes means that the plane of access is dislodged and therefore requires reorientation. The endoprosthesis is then deployed, traversing the stricture. The guide wire should not be removed immediately because it may facilitate the placement of a second stent should there be any misdeployment of the first stent. In this case, to minimize a bile leak, we placed a 7 French single pigtail plastic stent across the transgastric fistula, although oftentimes this is not required. Note that the entire procedure was performed only on sonographic and fluoroscopic view. Also, note that the fluoroscopy tower was rotated oftentimes to provide magnified and unmagnified images to facilitate different intraprocedural maneuvers. To observe such procedures performed in real time by the masters themselves, please register to attend Florida Live Endoscopy in Orlando, where the magic of endoscopy begins.
On behalf of the entire team of the Orlando Health Digestive Health Institute and our Center for Advanced Endoscopy Research and Education, we extend a warm invitation to join us on August 20 through 22 in Orlando for Florida Live Endoscopy 2026. This will be a unique meeting where we will celebrate the accomplishments of a generation of endoscopists while exploring the future of endoscopy. This will not be just another endoscopy conference, but rather will be a unique and lively gathering that spans generations, highlighting pioneering techniques and innovative breakthroughs. Prepare for a fascinating journey through the evolution of endoscopy. You will experience live demonstrations of the latest procedures, connect with renowned experts worldwide, and gain valuable insights from leaders who have shaped our field. Discover the expertise of 20 renowned international faculty members whose remarkable insights will elevate your learning experience. Celebrate the legacy of endoscopic pioneers and witness the future of endoscopy unfold. Register today and become part of this remarkable journey, where tradition meets innovation in the continuous evolution of endoscopy. Save the date for Florida Live Endoscopy 2026, the premier event showcasing history, excellence, and upcoming advances in endoscopy. Florida Live Endoscopy 2026, where the magic of endoscopy begins.